Hi, I'm Dr. Tam Cummings, and I'm a gerontologist specializing in dementia. This is Section 5, Tools for Staging Dementia, on your Dementia Caregiver Education series being brought to you by the East Texas Alzheimer's Alliance. What we're going to talk about are tools that you can use to stage your loved one's dementia that will also help your doctor see what's going on and help your families understand what's going on and also prepare you for what's coming next. Now, the number one cause of behaviors in people with dementia is untreated chronic pain. So one of the things that we're going to ask you to do is look at your PAIN-AD scale, which is Pain Assessment in Advanced Dementia, and make sure that as your loved one goes through the disease process, pain that is accumulated through a lifetime is treated. Now, 50% of the behaviors in people with dementia comes from untreated pain, and your loved one can have up to 3,000 milligrams a day of ibuprofen, Tylenol, or Aleve. And you can talk to your doctor about that. Your loved one can also have narcotic medication to treat chronic pain. Now, think about your loved one. Think about yourself. How much do you hurt right now? When I'm doing this live, I ask the audience, raise your hands if you hurt, and half the people raise their hands, and I tell the audience, the rest of you are just fibbing. We hurt. There is pain that is accumulated by living our lives. In graduate school, we were told that if we could suddenly feel the pain of a normal 80-year-old person, we would actually scream aloud and fall down. But because it is the slow accumulation of pain, the adding of arthritis in this hip, then arthritis in that elbow, then a different arthritis in your hands, a bursitis, a tendonitis. If your loved one's back is bent, if their spine is bent, that's actually the sign of dozens or hundreds of minute fractures. So think about how much you hurt right now. How much more would you hurt in 10 years? And wouldn't you want us to take care of that for you? You got to be careful about PRN medicines, though. We see pain medicine given to people with dementia, but it's given as a PRN. PRN means that I know I'm hurting and I know to go ask my nurse to give me that pill. But your loved one has dementia. Why in the world would we prescribe PRN medicine? How are they supposed to know now is the time to go get it? Also, your loved one's probably very good at predicting weather. As storms move around us, 2 days before the storm gets here, barometric pressure is already changing, and people with joint issues, people with arthritis, tendonitis, bursitis, can feel that change in pressure because their joints feel different. We have to medicate then before the storm gets here, always staying in front of pain. You've got to make sure your loved one is checked. And the way we check them is we use a tool called the PAIN-AD. This is official medical paperwork. Fill it out for your doctor. And it may take you doing that to get your doctor's attention. And if it's taking much more than that, it's time to change doctors. But what you're going to see on your staging tool is page 1 is going to have you measure how your loved one is breathing, their vocalization, their facial expression, their body language, and whether or not you can console them. And in each of these categories, there's a number of words that are describing the medical condition we're looking at. And page 2 of your PAIN-AD explains what it is each one of those words mean. So you're going to go through and look at your loved one and grade them. And you're going to keep this scale to the end of their life. And anytime you're concerned about pain issues, you just automatically get your scale out and check your loved one. 50% of their behaviors come from untreated pain, and we can treat pain. And even with narcotic medication if need be, but we can treat pain. We frequently see people in such severe pain that they can't relax and progress to death because they simply hurt too much. And so they hang on another 3 or 4 or 6 months in excruciating pain because no one realized we can't ask people with dementia, do you hurt? Because they have brain damage. They may not feel the hurt, but their body is experiencing the hurt, and we need to correct that for them. Remember your ADLs. One of the tools you're going to use is your ADL tool. And in this ADL tool, we don't use transfer. Instead, we're going to start with the other ADL things. And these are the order in which they are listed on your page. And this page is in your handout. This page is called Dr. Katz's Scale, the Activities of Daily Living, or physical self-maintenance activities of daily living. And you have to be hard on this. Now, it's hard for families to fill out the ADL tool, but the ADL tool actually gives your doctor a much truer picture of what's happening at home. And it takes that emotion out of it. You don't have to argue with your loved one in front of the doctor. No, really, you're wetting on yourself. Instead, you just give the doctor the paperwork. The hard part for families is taking the emotion out of it. You can either go to the bathroom correctly every single time, or you're now down from Cares for Self. There is no, oops, they had an accident. It's not an accident. It's now brain damage. It doesn't help the doctor help your loved one if you can't separate that they really are not toileting themselves correctly anymore. And if you think having to remind them was tough, you've still got several more step downs until you're at complete incontinence. These tools help your doctor see where your loved one is, also help your family see what's going on. Feeding means being able to eat without assistance. And that's what it means. If I'm cutting up your food, carrying your food to the plate, bringing you your water, if I'm doing things that are not normal for how you ate, you've now stepped down from eating without assistance. And this is hard to do because it represents that loss to you. And you're already looking at a person who's not the person you knew. That you've got to be able to take the emotion out of this. They can either eat without assistance or they now need assistance. And doing that helps your physician truly see your loved one, because your physician's probably not seeing them for an hour. It's probably only a few minutes. Your physical self-maintenance activities of daily living scale will help the doctor do better care because it shows them the true picture, even though your loved one doesn't look sick yet. For dressing, you can either dress yourself, undress yourself, select your clothing appropriately, wear everything appropriately, including everything that you should have on, or you can't. And dressing is very, very complex, and there's significant brain damage if the person has gone from can dress themselves to now needs assistance. In each one of the ADLs, that step down from you can do it yourself to now needing assistance is a severe amount of brain damage. Grooming is different for women than men, but basically we're doing something in our facial area somewhere around here, but also all the way down to our toes, our fingernails. Grooming is very, very complex, and it begins to be lost step by step. And I have families tell me, no, he still does all his own care. And I look at him and he's got scruff here and he's not neatly shaven. And that's not how he took care of himself. So he is not at number one anymore. He's now down to needs to be groomed with assistance. Ambulation, you and I ran everywhere. This means that I can move around the city or the grounds and I'm okay. The second step down of ambulates within the residence or in a 1-block radius, that doesn't mean we turn them loose in the neighborhood. That means they can safely step that many steps without falling. And people with dementia really don't understand they're only going to go to the neighborhood store and come back. They have a damaged brain. If you pay attention, the Amber Alert system is used more for a silver alert than it is for children. And when you see a silver alert going off, it's a person with dementia who's left their home and has not come back. You can't trust that that's going to happen. As the disease progresses, your loved one will eventually lose their ability to walk. And this is not them not trying to walk. This is brain damage. Okay, this has nothing to do with the physical therapist isn't a good physical therapist. This is brain damage. And eventually, if they live to stage 7, they become bedbound. Bathing is incredibly complex. Remember, we've talked about it's more than 4 dozen steps. It's our hardest ADL to do. And it causes a lot of pushback, a lot of combative behavior. But remember, the purpose of bathing is simply that we want a clean skin. We don't have to dunk you down in water. When you look at the behaviors that come with dementia, you'll notice the 2 big ones. And when we see these behaviors, be aware. These behaviors make people want to give your loved one an antipsychotic, and we try not to use antipsychotics in dementia behavior because it can actually kill the person with dementia. And most of the behaviors in dementia are actually being caused by untreated pain, an untrained caregiver who doesn't realize you're moving too fast, you're talking too fast, this person doesn't see you. And those things should be treated with pain medication and then agitated, angry, annoyed, aggressive person gets treated with an antidepressant. Everybody just take a breath in. Feet on the floor, hands in your lap, eyes shut, deep breath in, 2, 3, 4, hold, hold, breathe out, 2, 3, 4, 5, 6. Understand that there are behavioral triggers for your loved one. Any of these things can cause your loved one to have great difficulty. And it can be things like their pants fit them when you move them into memory care, but now they've gained weight and they don't fit. It can be that there's too much going on around them. The task is too complicated. You demanding they prove to you they can still dress themselves can cause your person to blow up because they can't figure out how to do those things anymore. The surroundings can be the surroundings of a new community, or it can be the house they've lived in for 40 years. It just indicates brain damage. The inability to communicate, depression, delirium, and remember that people with dementia have strokes. It doesn't mean they're major strokes, but there are other medical complications that arise as a part of brain damage. When behaviors occur, we ask ourselves, who, what, why, when, where, and how? Does this happen every day at the same time? Then we need to look at medicine. Is the same staff member always here? Well, we've got somebody that needs more training. What exactly happens? Where does it happen? When does it happen? What is going on? Because if we can figure this out, we can help the doctor treat the person. So when we look at people with dementia, we look at all kinds of behaviors that occur. And these are not behaviors happening because your loved one's a bad person, because God doesn't like them, because of anything other than brain damage. So common behaviors we see in dementia, people have hallucinations. They see things that are not there. They hear things or smell things that are not there. People have scatological behaviors, and that is everything from I felt something behind me, I reached behind me, now I've got something icky on my hands and I'm trying to wipe feces off on the wall or on the bed or on the towel. It can be that your husband is peeing in the trash can, peeing in the corner, peeing on the silk plant. He's not doing it on purpose. It's brain damage. You may have a loved one who actually climbs up on the bathroom sink and defecates in the sink itself. That's a behavior that's associated with using an outhouse where a child would have had to have crawled up on that plank and scooched over to where the hole was to go to the bathroom. Your loved one may do all sorts of things like that, including eating their own feces. And when that happens, the person is put in what's called a backward jumpsuit that's Velcroed at the wrist and at the ankles. Your person may be so hyperoral, they put everything in their mouth, and that doesn't make them bad. It's simply an indicator of very extensive brain damage. People with dementia have delusional behavior. Delusion are beliefs that are not real. You're stealing from them. You're a bad person. You're trying to get them. They're damage in their frontal lobe and our frontal temporal dementia people mean they especially have a lack of empathy on their face, a lack of emotion on their face. Their speech is affected. Verbal and physical agitated behaviors. Remember, people with vascular dementia are more likely to have verbal and physical aggression as part of that, and that would be treated with antidepressant medication. People with dementia develop sexual behaviors. We've had people that have lived as heterosexuals as dementia progress appear to be more same-sex interested. Your beloved husband may not remember you anymore because of brain damage, but has picked a woman in the dementia community who looks very similar to you. Your loved one may become very sexually active. And both male and female brains produce testosterone and estrogen. And in the case of dementia, damaged brains in both sexes can begin to produce extreme amounts of testosterone, and you can get a very touchy-grabby, sexually active, wanting to be active person. When that happens for your loved one and it's out of their norm, we let the doctor know, and the doctor will prescribe some type of estrogen that will rebalance the testosterone. People with dementia fall down. It's not part of bad care. It's part of the disease of dementia. And if you talk to professional caregivers, they have actually in their career caught people hundreds of times as they started to stumble and fall. But falls are part of the disease of dementia because of brain damage, and urinary tract infections are part of the disease of dementia because of brain damage. Your loved one gets angry because of ADLs, not able to do their ADLs, or when we are trying to assist them with ADLs. And it's not because they're mean, bad people. It's because they have brain damage and they don't understand why are we doing these things to them. Pain, anxiety, and depression behaviors. When you see these behaviors, the first thing we always do is check for pain. We do pain assessment first. Then, if we're still seeing these same behaviors, all of these behaviors are also indicative of anxiety or depression. So somebody rocking or somebody laying very, very still, somebody laying stiff and straight, somebody pulled up in a fetal position, somebody who's physically or verbally aggressive, and that can really hurt your feelings so much you don't realize this is actually part of the disease we need to be treating. This is not purposeful behavior. Changes in sleep or appetite. And then the instincts you used as a parent on your children. Facial grimacing, eyebrows pulled together, frowning, looks like they hurt. And then other signs of acute pain, remember, are slapping, punching, kicking. Suddenly out of nowhere, you get slapped. That's not somebody being mean. That's actually acute and severe pain. Grinding teeth, blinking, picking at the skin until you actually pick holes in the skin. That can be pain, but it's most commonly anxiety. And then screaming or biting at the caregiver. Again, these are indicators of pain. So if I bite you, you will leave me alone. You will stop coming around me. It is a defensive action to protect oneself because even touching me may hurt me. And if you touch me and hurt me, you need to apologize. If you know you're going to hurt me moving me because I've got a bad knee, apologize before, during, and after. Other challenging behaviors include things mainly that involve hitting, spitting, punching, resisting care, resentfulness. All of these things make your job as a family caregiver much harder, and they are challenging things for our professional caregivers, but we go back and treat pain. Disruptive vocalizations are things that drive you crazy, and this is a person screaming and moaning. Now, repetitive questions are considered part of disruptive vocalization, but repetitive questions are earlier in the disease in stage 5 when the hippocampus is damaged, and now I'm asking you over and over and over again, when is my doctor's appointment? Verbally agitated disruptive vocalization is screaming, moaning, yelling, no, don't touch me, no, don't touch me, when there's nobody near this person, and just constantly calling out, and this goes on for hours. You need to immediately do a pain assessment, because when people are behaving that loudly, they are trying their best to tell you, I'm hurting somewhere. So use your pain ad. And if your person's in a community, you may even actually have the community have to do 6 or 7 different shifts monitoring your person and marking the pain ad before you can get the doctor's attention. But you've got to treat that behavior first for pain. The Dementia Behavioral Assessment Tool is the 7-stage tool in your handouts that allows you to check off the behaviors you're seeing in your loved one, and that allows you to see how advanced the disease process is. You and I are stage 1 in the disease process. We're aging normally. We're going to live and die at home. We're never going to require care or assistance. Stage 2 is called mild cognitive impairment. And as the family caregiver, when you read the details on stage 2, your most common thought is, oh crap, I've got it too, because it says things like you forget names. Remember, this is not my name your loved one doesn't remember. It's your name they don't remember. Okay, so it's those types of things. So normal brain function, and these are things we want to cover real quick, because as a family caregiver, you have normal brain function, but because you're the caregiver for somebody with dementia, your first thought is, crap, I've got it too. So if you have walked in a room and you don't remember what you went in there for, that is not dementia. That is normal brain function. It means you're stressed. It means you're tired. It means whatever you're doing, your brain doesn't care anymore. In another form of common memory issue that you see is that if you're a grandparent or if you're a parent with a lot of kids, and to call that certain kid's name, you had to list off all the names of your grandchildren before you pulled the right name. That's not dementia. That is normal brain function. If that good looking actor, you can't remember, oh, you can see his face in your brain. You can feel his mouth, his name in your mouth, and you can't see it. You watched that movie last night and you think and you think and you can't see it and you think, I got it too. And then at 3 a.m, you sit up and yell, Brad Pitt, that's who that guy is. All of that has to do with is how you learn the information. I learned Brad Pitt because he was with Jennifer Aniston. So he's in my Jennifer Aniston file in my brain. He tried to get out and go over and crawl in my Angelina Jolie file, but that didn't work. I learned him with Jennifer Aniston. When you can't remember that thing, that movie, that moment, that whatever it is you're trying to remember, take a deep breath and say to yourself, how did I learn the information? And your brain will begin to look through its files until it finds the information and pulls it out for you. Okay. So stage 2 is where family caregivers are most likely to think, I've got it too, but more than likely what you're dealing with is your stress. Okay. Stage 3 is where the word dementia is used for the first time. And remember, dementia is now the diagnosis. We want to know which dementia. This is where we would intend to start medication. And as you do your staging tool, I assume because you're on this series that your loved one is probably in stage 5 of the disease. And it's just because I know that's when family members begin to reach out for help. That's when you could finally get your loved one in to get diagnosed. It's not that you were bad, you just couldn't get there. But start your staging tool in stage 3. Check off every behavior you remember. And as you go through those behaviors, try to think about what was the year that happened in? When did I notice? And that way you'll be able to determine, did this process begin just a few years ago, or has this been in place much, much longer? As you go through, check off the behaviors that you see, and you're not going to check every behavior. Some things are listed on the Dementia Behavioral Assessment tool to say this could be a different dementia, this could be Lewy bodies, this could be FTD, and that means a different thing. So just start checking off in stage 3, check off every behavior you notice. And when you stop, take a moment and take a breath. I grade harder than you do because I don't have emotional attachment. The person can either do it or they can't. I am usually a half a stage or more in front of the family caregiver. So as you're staging your loved one, get another friend to look at it with you, have your children do a staging tool as well, and see if you all come out to about the same place. The staging tool is going to help you to understand that it's real. It's so real that your loved one's behaviors are actually how we build the tool, because these are the behaviors a person with this level of brain damage will display. And then the tool tells you these are the behaviors that are coming next. The tool tells you this is how much brain tissue is gone, and this is what my loved one's mental equivalency is. So after you do the staging tool, you realize your loved one can't live alone in stage 5. They're not capable. That's like leaving a 12-year-old alone. Your loved one needs care in a facility. Stage 3, and then stage 4. Stage 4, remember, is moderate dementia. This person gets easily agitated. This is typically when adult children notice something is wrong. And this person has good social skills. They may still be driving. They may still be going to work. But in testing, they're now starting to look to family members to give the answers to the questions. And that's painful for family members because it hurts you. Stage 5 is where most people are diagnosed. Stage 5 is where I'm assuming your loved one probably is because you're looking at this series. Stage 5 is divided into 2 stages. The first stage is the equivalent of a 12-year-old to an 8-year-old. The second half of stage 5 is an 8-year-old to a 4-year-old. Stage 5 is when bladder incontinence begins. Stage 5 is when your person is most likely to accuse you of stealing from them, or other people are stealing from them. And remember, they don't physically look sick, even though there is significant brain damage. In the beginning of stage 5, this person may have a legitimate sounding conversation for 45 minutes to an hour before it all begins to repeat. And when I'm talking to your loved one, if I start using old memory with them, tell me where you're from, where did you grow up, what's your daddy's name, what was your mama's name, tell me the name of your siblings, I can stir up old memory. And for the next few days, Your loved one will talk about old things that have happened way back in their lifetime. Stage 5 people don't begin to look sick until the end of stage 5. And remember, they don't go to sleep Wednesday night in stage 5 and wake up Thursday in stage 6. You're going to see a fluctuation in a movement. You're going to look at them one day and go, it's stage 6, it's stage 6. And then a week later, you're going to go, nope, nope, still in stage 5, still in stage 5. And then a week later, you'll go, well, maybe 6, maybe 6. And then over the course of a month or so, you'll realize they have moved into that stage. There is no repair. There is no going back up the stage. People do not get better. The brain does not get better. We have no way to stop this. The person continues to decline and the behaviors match the areas of the brain that are still functioning. Stage 6, your person now looks sick. This is called severe dementia. They've now lost a pound of brain tissue. Language and speech are rapidly being lost. It's harder and harder for them to do social skills. Their inability to move their body properly is showing. Their gait is shuffling. They're now bent. They're now beginning to lose weight. And that person that you thought their body was so healthy that the disease is not really affecting it, now you begin to see the impact on the rest of the body. They will now begin to look sick, and the normal weight loss from stage 6 to stage 7 in death is 1/3 to 1/2 of the body weight will be lost. Dementia doesn't care that your loved one was a great big person. They don't care that they were an athlete. They don't care. The brain runs the body. So as the brain becomes more and more damaged, your loved one's body works less and less effectively. And finally, some of you will have your loved one live into stage 7. This is the bedbound stage. Most language is gone by here, but that doesn't mean your loved one can't suddenly sit up and say, hello, I love you. Those things happen in dementia. The FTD staging tool is different. You're going to go to the website theaftd.org, click on the top to what is FTD, click on the FTD descriptions, figure out which one you have, and then go back to your doctor to talk about which one it is and get in a support group. This dementia is not like the other dementias, and your person is probably not in their 70s, 80s, or 90s. Your person is going to be much younger. So this is very, very difficult. When you use the FTD staging tool, this tool is set up slightly differently. In this tool, all of the dementias are listed across the top of it. You pick the column with your loved one's dementia in it, and then you go down that column. When you get to stage 3, if there is an X in the column, it means that that behavior is associated with that form of FTD. It doesn't mean your person has it, but if your person has it, blacken the box out. As you go through checking off the behaviors that you see, you'll then know which stage your loved one is in. In stage 6 and 7 on the FTD staging tool, there are no more X's in the boxes because in stage 6 of the disease, all dementias are considered the same due to the amount of brain tissue loss. An unusual thing in frontal temporal dementias, especially the communication FTDs. In the midst of all this brain damage, your person will suddenly pick up a paintbrush and begin to paint like a master artist. And that will continue on for several months or even a few years, and then that will be lost. And we don't understand that at all. We just know that in a certain part of the disease, some of your loved ones will become absolute artists. It doesn't mean their brain has suddenly recovered. It's actually a sign of the progression of the dementia. The long goodbye is something that families go through, and this is the process of grief that you have because your loved one is dying over a period of a decade or longer. And so you may go through the stages of grief over and over and over again. You may have family members that are stuck in denial or stuck in anger. You may have even reached a point where you say, I've grieved all I can grieve. And as you grieve, realize that in stage 5, you are now grieving as though your person was actually dead. It is called post-death grief. And family caregivers of people with dementia experience post-death grief, even though their loved one is still alive. Spirituality in dementia continues to be important. We know that for your loved one, if they grew up as a spiritual or religious person, it is important that we continue to do these things for them. And we know that having these familiar spiritual rituals or icons to hold, like prayer beads or rosaries, that these decrease agitation and they actually increase the quality of life for the caregivers and the person with dementia. But remember, church is different now. The spiritual event is different. We have a quick prayer, we sing because we can still sing. We love to sing. Singing is fun. And then our lesson is God loves us, our Great Spirit loves us, our Creator loves us. It's going to be better. Life is going to be all right. Prayer and song. It is a short thing. It is not a long, hour-long service. It is 15 to 20 minutes because that's all the damaged brain can handle. The cycle of life theory and gerontology, we follow a cycle of life theory, and that theory says that I was born in the fall and I will die in the fall. My mother was born in the summer and she will die in the summer. The cycle of life is 30 days before the birthday and 60 days after the birthday. That 90-day window is the cycle of life. 80% of us after the age of 25 will die in our cycle of life. And if you're a religious or spiritual person, our great religious text, whether it's the Bible, the Torah, the Quran, Buddhist or Hindu, all speak about a time to be born and a time to die, that there is season and purpose in our life. And in dementia, in life, even people with dementia and cancer still die within their cycle of life. So I begin to pay a lot of attention to your loved one when we're in that 90-day window around their birthday. The 20% who don't die in their cycle of life either had a medical event that interceded their death. So they had a massive heart attack, but they were in the hospital when they had it and they were saved, or they died in an accident or something else happened to them. Otherwise, we die in our cycle of life. The actively dying tool is a tool that we developed because it took 9 months for life to start, and the process of actively dying is also 9 months. You have a tool in your handouts to help you follow this. In the final months of life, there is a significant change, and even though medicine is there, care is there, food is there, a roof is over their head, everything is there, your loved one simply is not stable. The doctor will change the diagnosis and add adult failure to thrive. And even people who have stopped talking will talk about missing a loved one. And this is no longer, I miss mama's peach cobbler. This is, I miss mama. They begin to have clear and vivid dreams about loved ones that are gone, and they begin to very slowly withdraw from the activities that they're in. In the final weeks, there's less and less eye contact, and your person is now bedbound. And when we walk in the room, they're no longer looking at us. Instead, they're looking up and pointing and reaching and seem to be talking to something up above them that we don't see. There's less and less interest in food and drink, and they may even have strange feelings in their limbs because the body is slowly preparing itself to shut down. The body's like a giant factory. There's not just a switch to throw, there's multiple things that happen. And the strange feeling in the limbs is the slowing of circulation very gradually. Your loved one will tire very easily, their voice will weaken very easily, and they have conversations with people that are not there. And they tell us when we're in their rooms that there have been strangers in there telling them it's time to come on, and they've told them to go away. It's important now that you're not afraid of the silence, because silence may be all that's left in this moment of life. In the final days, it's important that you give permission, but understand when you say, Mama, if you're ready to go, you can go. It doesn't mean your mother's going to look at you and go, okay, bye, and die in that instance. The body is moving at its own pace. There's less and less interest in food and drink, and that used to panic us. And we thought, well, if we don't get food and drink in them, they're going to die. And we found out that even if we put tubes in people and gave them hydration and nutrition, the body doesn't absorb it because the body has moved to the process of the end of life. There is a general restlessness, and then there may be very calmness. The person may have leg tremors or arm tremors. And again, this is because circulation is slowing, and the long, elongated muscle cells in the arms and legs are not getting enough oxygen, and so they tremor as a result. Pulse and breathing are starting to slow, and then they move back up to normal, and then they begin to slow. Kidney and liver function begin to slow, and the person can suddenly wake up, be very alert, ask for their favorite meal. We call the family comes running, the person eats their favorite meal, the family shouts hallelujah and goes home, and the person dies that night. And that is a common thing that also happens in dementia. Circulation is now continuing to slow, and we're beginning to use a pillow to turn and position your person every 2 hours to avoid skin breakdown, to avoid a decubitus ulcer, to avoid a bed sore. Bed sores normally take 24 to 36 hours to begin forming. In the final days and the final day of your loved one's life, they can happen in a matter of minutes. So it's critical that we turn and care for your loved one. In the final hours on your handout, your tool, it is listed in the order in which the human body begins to shut down function. The person may be calm and then may be restless. They may or may not respond to speech or sound. They do not follow our movement around the room. Instead, their eyes are half open in what we call doll's eyes. We ask you to continue speaking to your person as though they can hear you and continue to interact with them. And trembling and twitching in the limbs can now begin to be more noticeable. And if the person has some rare forms of frontal temporal dementia, the electrical impulses firing through the damaged brain can actually make them jump off the bed in these final hours to where their body actually physically lifts off the bed and then falls back down. That will pass in a few minutes, and it's very rare, but it's just it's just an electrical charge firing. You now begin to hear gurgling, or what is called the death rattle. The brain is no longer using energy to swallow, so saliva is pooled at the back of the throat. And as the person breathes in and out, that is the gurgling sound that you hear. Your person is now in a semi-comatose state and has a semi-comatose appearance. Their mouth is open. They are breathing only through their mouth. Fever is now coming and going as the brain recognizes the body is full of infection and it tries to raise the body temperature, but it can't. Kidney function is now very low. Modeling is where circulation has slowed to the point that unoxygenated blood is pooling in the extremities, so the hands and the feet may get a blue or a purplish color to them. Wounds can now happen in a matter of minutes or a couple of hours. Heart and respiration are gradually slowing and then may speed up and then slow down again. And there may be an odor present, and that is because there's now necrotic or dead tissue in the body. The person begins to have apnea and Cheyne-Stokes breathing. Cheyne-Stokes breathing is a very heavy, ragged breathing, and when your person breathes it, the stopping of breath between breaths is apnea. So you will see your person take a heavy, ragged breath, and then an exhale, and then there will be no breath. And in your first thought, you'll think they've died, and then you'll realize their pulse is going at their neck. And anywhere between 5 seconds and 90 seconds later, they will take another deep, ragged breath and exhale, and then there will not be a breath for a period of 5 seconds to 90 seconds. When apnea and Cheyne-Stokes breathing begin, it means that the end of life is minutes or only a few hours away. In the final breath, the loved one may make a pa sound, and there may be spittle or foam at the corner of the mouth, and in that moment, death occurred. The body will immediately appear to shrink. If you're a religious or spiritual person, this is the belief the soul is leaving the body. The body will become pale and cool and gray quickly because part of your coloring comes from red oxygenated blood. The eyes and the mouth are typically open in death. This is not a grimace or a sign that somebody did a bad thing. It is simply the normal presentation in death. The eyes become flattened because there is no more blood pressure, which is part of what makes the eye round. The body may have a slight movement as the final electrical charge leaves, and the body may release urine or stool. And in that moment, grief begins again. You won't remember the funeral. You won't remember the moments that happened after your loved one's death, and that is normal. You may have numbness, you may feel anger, you may have regrets. You may actually even get sick 6 weeks to 6 months after your loved one, and you may feel funny in your body to the point that you even go to the doctor and say, I'm having these headaches, my stomach hurts, I don't understand what's going on, and what's going on is that you're grieving. You may have outbursts. Your sweetheart brings you a cup of coffee and you chop their head off. It's not the coffee, it's not your sweetie pie, it's grief. You may get surprised because you find yourself picking up the phone to call your loved one, or you find yourself driving to their house. And then because it was dementia, that makes you think, oh my God, I've got it too. And in reality, this is grief. You may have reoccurring pictures of your loved one in your head. You may have dreams about your loved one, especially right after their death. And these are all normal things. This is what humans report around the world. When we talk to kids about death, it's important that we allow preschoolers to grieve, that they see us crying and they're allowed to cry. But preschoolers are very concrete. Their brains are not developed enough to understand death. What they know is that we're crying and we miss grandma, and grandma went to heaven, and heaven is up there, and airplanes fly up there. So we should get an airplane and fly up there and get grandma. And that may sound shocking to you. The preschooler may say, we buried grandpa at that cemetery. He's in that box. Let's go get a shovel and go get him and bring him home. They're very concrete. Death is not eternal to them. Death means this person's gone and we can go get them back. School age and preteens very much understand that death is final, that this person is gone. But if we don't let them grieve and let them see us grieve, we can change how they view death for the rest of their life. And teenagers, well, you may want to kill them. I don't know what to tell you. Teenagers are different. Their brains are doing something unique in their teen years. Their adolescent brain doesn't finish developing until they're about 23 or 24. The full adult brain doesn't finish developing until about 32. Teenagers look at their grandparents. They love them. They miss them. That this is going to be terrible, but they can't imagine why anybody would want to live to be that old, because they're pretty sure nobody after the age of 25 is having fun. And so for them, they go to the funeral, they're appropriate, they're grieving, they cry, but then they may ask to go see their friends. They need some money and the keys to the car. They want to go somewhere else for a while, and that is normal. A new way of counting time for you will begin. It becomes the first Mother's Day, it becomes the second Valentine's, it becomes the third Christmas, it becomes the fourth Father's Day. And this will go on for about a decade, because that's how long it takes to actually grieve someone you love, a parent or a spouse. If your death is a child, then you grieve that for the remainder of your life. But for your spouse and your parent, grieving takes about a decade to fully grieve. Now, in your handouts, you've got tips on doing meditation to help your stress level. You've got a caregiver burden scale so that you can test your stress levels. You've got a geriatric depression scale so you can test your depression. And then we also want you to do Zaret's burden interview, the caregiver stress test and grief test, and then the GAD-7 anxiety screening test. If you have questions about these, take the test, take them to your doctor, or talk to your doctor about the stress level you're feeling. If you say to the doctor, I'm a family caregiver for a person with dementia, and your physician says, gee, that sounds tough, you need to get another physician, because you need someone to hear and understand your level of stress is real and it's overwhelming. Everybody just breathe. Put your feet on the floor, your hands in your lap. We're going to take 2 deep breaths in to the count of 4, hold for 2, breathe out to the count of 6. Feet on the floor, hands in the lap, eyes shut. Deep breath in, 2, 3, 4, hold, hold, breathe out, 2, 3, 4, 5, 6. Deep breath in, 2, 3, 4, hold, hold, breathe out, 2, 3, 4, 5, 6. That concludes number 5. Your 6th session is on caregiver stress, grief, and guilt. Take care of yourselves.